Hello, everyone, and welcome to our first module on meningitis. So meningitis refers to inflammation of the meninges. So before we can talk about meningitis, we have to talk about what are the meninges. So the meninges are three membranes that cover brain tissue, and they're depicted in this image on the slide here. So this is brain tissue down here. This is the skull that I'm marking with my pen right here. And beneath the skull and covering the brain, you find the meninges shown here. There are three layers to the meninges. The first is the dura mater, which is very thick, and then there are two thin layers called the arachnoid and pia mater. And sometimes you will hear the term leptomeninges, and the prefix lepto means thin. And so the thin leptomeninges are the arachnoid and pia mater, distinct from the dura mater, which is a more thick membrane. And so if you understand what the meninges are, then it's easy to understand what the subarachnoid space is. This is the space below the arachnoid matter. That's why it's called subarachnoid. And it's between the arachnoid and the pia mater. It's this space shown in blue right here in this cartoon. And it contains large blood vessels like of the circle of Willis. It also contains cerebrospinal fluid. And so what happens in meningitis is this subarachnoid space becomes inflamed. The arachnoid and pia mater are inflamed. There can be white blood cells in the cerebrospinal fluid. And the reason this region can become inflamed or infected is because it contains large blood vessels. So pathogens can travel through the bloodstream, and then they're going to enter this subarachnoid space right here. And that's going to cause inflammation of the cerebrospinal fluid and also the arachnoid and pia mater. And so if you understand all that, then it's fairly easy to understand that meningitis is inflammation of the leptomeninges. It involves the subarachnoid space, like we talked about in the last slide, and it involves the leptomeninges, meaning the arachnoid and pia mater. Usually meningitis is an infectious process. It can be caused by viruses, bacteria, and fungi. And I'll talk about some of these things in this video and also some of them in the second video on meningitis. Rarely you can have non-infectious forms of meningitis, so cancer can spread to the meninges, sarcoidosis can rarely involve the meninges, and there are other inflammatory disorders that sometimes involve the meninges and lead to meningitis-type symptoms. Okay, so that's a nice segue into the symptoms or clinical features of meningitis. So first of all, most patients with meningitis have a fever because it's an inflammatory process. They also usually have a headache, and that's because of inflammation of the meninges, which are found inside the skull as part of the head. Another classic feature of meningitis is photophobia. Patients with meningitis will say that bright lights bother them. They will want to sit in a dark room. And this is because light constricts the pupil and the iris, and this pulls on the meninges. So bright lights are bothersome for this reason. And then a super classic feature of meningitis is so-called nuchal rigidity. So let's talk about what this means. So the nape means the back of the neck. If you look at this drawing right here, this is the nape of the neck. And nuchal means related to the nape. So nuchal rigidity means it hurts to move the back of the neck. That's because when you flex the neck, sort of like this person is doing in this cartoon right here, you stretch the meninges, and that's going to be very painful in anyone who has meningitis. There are two classic signs of meningitis, so let's talk about those now. The first one is called Brzezinski sign. This is a depiction of how you elicit Brzezinski sign shown in panel A right here. So you lie the patient flat, and then the examiner lifts the patient's head off the table. And if there's irritation of the meninges, the patient will involuntarily lift their leg. That's because when you tilt the head, you stretch the meninges, and by lifting the legs, you relieve some of that tension, and so the pain gets better. So the patient will involuntarily lift their leg to try to minimize the pain. The second classic sign of meningitis is Koenig sign. This is a depiction of Koenig sign here in panel B. So the patient bends their thigh at the hip with the knee at 90 degrees, and then you ask them to extend their leg. And when they do this, that stretches the meninges. And so if there's irritation of meninges, this will be painful. And this is called a positive Koenig sign. Both of these are not actually specific to meningitis. They're actually signs of so-called meningismus, which means irritation of the meninges. Usually that's caused by meningitis, but you can also elicit both of these signs in patients who have a subarachnoid hemorrhage, which I talk about in other videos. In a subarachnoid hemorrhage, one of those blood vessels in the subarachnoid space ruptures, and there's bleeding into the subarachnoid space, and this will cause meningeal inflammation. This can actually produce a clinical picture very similar to meningitis. The big difference is that the onset of subarachnoid hemorrhage is usually abrupt and sudden compared to meningitis, which is usually a slowly evolving inflammatory process that occurs over hours or days. Okay, now let's talk about how you make a diagnosis of meningitis. So first of all, you suspect meningitis when patients have suggestive signs and symptoms, like all the things we've talked about in the last few slides. But then the way you make the diagnosis is by doing a lumbar puncture. This involves inserting a spinal needle into the spinal column, like what's shown right here in this picture, and then collecting a sample of cerebrospinal fluid. Remember that meningitis involves inflammation of the subarachnoid space, which contains cerebrospinal fluid, and there's cerebrospinal fluid in the brain, but that's continuous with the CSF that's down in the spinal cord. So you get a sample of that spinal fluid, and it will contain cells and other indicators of infection if meningitis is present. So that's a nice segue into talking about lumbar puncture. So let's talk about this procedure, which is a diagnostic procedure done to make the diagnosis of meningitis. So the way you perform a lumbar puncture is you ask the patient to lie on their side, like what's shown here in the upper panel. You then identify the iliac crests, which are the top of the pelvic bone. You should be able to identify the left and right iliac crests easily by feeling beneath the skin, and you make a line between those two crests. That line is usually at the level of the fourth lumbar vertebral body, and so just below that line is the L4, L5 interspace. And this is the ideal place to put the spinal needle for a lumbar puncture because it's way below the termination of the spinal cord. You would never want to put a needle into the spinal column at the level of the cord itself because you would poke into the cord and that could cause permanent neurologic damage. You want to put the spinal needle into a level below where the cord is ended, where you just have free nerve fibers running in the CSF. They're usually separated by the spinal needle and you don't do any damage. When you put the spinal needle into the L4, L5 interspace, you advance it until it enters the subarachnoid space. You try not to pierce the pia, and this is something you'll get taught when you learn how to do this procedure on your rotations. And then in the subarachnoid space, that's where CSF is, and you can collect a sample. Usually drops will begin to come out of the needle that you can collect in a tube. For your board exams, they're going to want you to know the anatomy of the lumbar puncture procedure, meaning the pathway the needle takes as it goes from outside the body into the subarachnoid space. So let's talk about that pathway now. So first of all, obviously the needle has to pass through the skin and the subcutaneous fascia and fat. But after this, it goes through three ligaments. The first is the supraspinous ligament, then the interspinous ligament, and then the ligamentum flavum. Once it passes through the ligamentum flavum, it is in the epidural space, which is the space above the dura mater. The next place it's going to go is through the dura mater, and then right beneath the dura mater, you find the next layer of the meninges, which is the arachnoid mater. After the needle pierces the arachnoid mater, it enters the subarachnoid space, and this is where you find CSF, and this is where you can take a sample of CSF to make a diagnosis of meningitis. Besides obtaining a sample of CSF for diagnosis of meningitis, another thing you can do when you perform a lumbar puncture procedure is measure the so-called opening pressure. This is the pressure of cerebrospinal fluid inside the spinal canal, and it's the same thing as the intracranial pressure, or ICP. So if you look at this drawing right here, if we put a needle into the spinal canal right here and measure the pressure, that's the pressure of cerebrospinal fluid at this location, but also all the way up and into the head because the cerebrospinal fluid is continuous through that whole region. So the opening pressure is a measurement of intracranial pressure, and it can be high when patients have raised intracranial pressure for any reason. So in order to measure the opening pressure, the patient first of all has to lie on their side. If they're sitting up, it will change the hemodynamics and you'll get abnormal pressure results. Then after you stick the needle in, you simply hook it up to a tool to measure the pressure, and a normal pressure is up to 25 centimeters of water. You can see elevated pressure more than 25 in any situation where there's high intracranial pressure. But you also see it in many forms of meningitis because, as we'll talk about shortly, meningitis often raises the opening pressure. So patients with bacterial meningitis often have a high opening pressure because they have a high intracranial pressure from all that inflammation in the meninges. You also often see elevated opening pressures in patients with fungal meningitis or tuberculosis meningitis. Doesn't usually happen in viral meningitis, although it can in some cases. And then remember what I said, the opening pressure is the same thing as the intracranial pressure, so it can be elevated in patients who have any cause of elevated ICP, including hydrocephalus. You can also use a lumbar puncture as a therapy for raised intracranial pressure. You can put the needle in and drain some CSF out until the pressure comes down. So in some patients who have certain conditions where the ICP is chronically high and it's causing clinical symptoms like headache, you can drain some CSF to lower the intracranial pressure. Okay, so once you get a sample of CSF in a patient with suspected meningitis, you send it to the lab, and they basically look for four things. First of all, they look for the presence of white blood cells, they measure the amount of protein and glucose, and then they send a sample of the CSF for a culture to try and grow any pathogenic organisms. So before we talk about abnormal CSF findings in patients with meningitis, let's talk about what normal CSF looks like. So first of all, normal CSF in a patient who is healthy and does not have any subarachnoid bleeding or meningitis should be clear. This is what it looks like in this picture on the slide right here. If the CSF is yellow, that's bad. Yellow CSF indicates xanthochromia. This means that there's been bleeding into the subarachnoid space, like you can see in patients with subarachnoid hemorrhage. There are normally just a few white blood cells in the CSF, and they're usually lymphocytes, so it's normal to have up to 5 lymphocytes, but more than this is not normal. The protein level is usually low, less than 45 milligrams per deciliter, and the glucose level is usually higher than that, usually higher than 45 milligrams per deciliter. The glucose level in the CSF is usually about 2/3 of the blood glucose. So a normal blood glucose is about 80 to 120, and then 2/3 of that would give you a value greater than 45, which is what you normally see. Shown on this slide is a summary table of the CSF findings in various forms of meningitis, whether they are bacterial, viral, or meningitis due to fungi or tuberculosis. So first of all, the opening pressure you should be aware of is often high in meningitis. The inflammatory cells obstruct the ability of the arachnoid villi to absorb CSF, so CSF often accumulates in the subarachnoid space, so it's very common to see a high opening pressure in CSF from any cause. It's often high in bacterial and fungal or TB. It's sometimes high in viral, but it also can be normal. In general, viral meningitis does not cause as significant an inflammatory response as other forms of meningitis. Patients tend to be less ill appearing, and they tend to have less impressive CSF findings. So the opening pressure is sometimes normal in viral meningitis, but otherwise it's usually elevated. The type of cells that you find in the CSF tell you something about what kind of infection is going on. So most forms of bacterial meningitis raise the neutrophil count inside the cerebrospinal fluid. In contrast, viral, fungal, or TB meningitis usually raises the lymphocyte count in the CSF. Protein levels usually go up in meningitis because you have inflammatory cells producing cytokines and other proteins. The only exception, once again, is viral meningitis. Sometimes the protein level is normal because the inflammatory response is not as impressive or significant, but usually you see elevated protein levels in most forms of meningitis. And then the glucose level is usually normal in viral meningitis because viruses don't consume glucose. But in any other form of meningitis, the pathogens consume glucose and the glucose level gets low in the CSF. So bacterial meningitis almost always has a low glucose in the CSF. Same is usually true of fungal and TB meningitis. So this table on the slide here is super high yield for board exams and also real life. Make sure you understand the different cells, protein, glucose, and opening pressure findings in the 3 different forms of meningitis. Let's talk about some of the complications of meningitis. So first of all, patients with meningitis often develop seizures when they are acutely ill. All that inflammation in the meninges can irritate the brain itself, and this can trigger the onset of seizures. This is relatively rare in the modern era where we have antibiotics, but years ago when we had no good treatments for meningitis, hearing loss was very common in patients who recovered from meningitis. And that's because the meninges are contiguous with the cochlea. So inflammation of the meninges can damage the cochlear nerve and the cochlea itself. So many people hundreds of years ago who survived meningitis would be deaf afterwards. Another classic complication is communicating hydrocephalus. So scar tissue and white blood cells that are present during meningitis and even after it has resolved can obstruct the reabsorption of cerebrospinal fluid. And this can cause hydrocephalus. It's a form of hydrocephalus called communicating hydrocephalus, which I talk about in other videos, where all the ventricles of the brain can become dilated. And then finally, death can unfortunately develop from meningitis. There are a couple of ways this can happen. First of all, the intracranial pressure can get so high that the brain can herniate. That's one way you can die from meningitis. Also, patients who have meningitis often become septic and they develop septic shock. So this is another way that death can occur. And most of these really bad complications that I'm showing on the slide here, most of these come from bacterial meningitis. They're much, much less common in viral and other forms of meningitis. So the treatment for bacterial forms of meningitis, which are the most dangerous forms, is with antibiotics. And ideally, we would choose antibiotics based on culture of the cerebrospinal fluid and blood, which would tell us exactly what the organism is and what antibiotics it's sensitive to. Problem is that culture can take days, so you can't wait for the culture to drive your choice of drugs in a patient who you think has bacterial meningitis. So in actual practice, what we do is we empirically choose drugs, and by this I mean we choose drugs without knowing exactly what organism is causing the infection. And we choose the drugs based on the patient's age and comorbidities, and also based on the findings of spinal fluid like the cell types, protein, and glucose. If these things indicate a probable bacterial meningitis, then we use the patient's age and comorbidities to empirically select antibiotics. So there are basically 4 antibiotics that we use to treat bacterial meningitis empirically, meaning before we have culture results. And all four of these drugs are used because they cross the blood-brain barrier and they have very good penetration of the CSF. So the first drug is ceftriaxone. It's a cephalosporin antibiotic. It covers strep pneumo, Neisseria meningitidis, and H. influenza type B, all of which are common causes of bacterial meningitis. Importantly, though, we don't give this drug to newborns with meningitis, and that's because it's very heavily protein-bound. It binds to albumin and displaces bilirubin. And in newborn babies, this raises the risk of kernicterus. Another bacterial meningitis antibiotic is vancomycin. It is good at covering strains of strep pneumo that are resistant to cephalosporins. So we often give ceftriaxone together with vancomycin, and this gives us better coverage of strep pneumo. Ampicillin can be used to treat bacterial meningitis. It's good at covering group B strep, which causes meningitis in newborns. It also covers listeria and some E. coli. These are all potential causes of meningitis in newborns, and listeria can also potentially cause meningitis in older adults. And then finally, gentamicin is given with ampicillin in cases of bacterial meningitis. Gentamicin is an aminoglycoside, and it's synergistic with ampicillin, meaning it makes ampicillin more effective at bacterial killing. And so by giving gentamicin together with ampicillin, you get better gram-negative coverage of bacteria like E. coli. So I'll finish this video with this slide, which is a slide that you've got to learn for your STEP exams and your clinical rotations. This will come up again and again. This slide summarizes the common pathogenic causes and the empiric treatment for bacterial meningitis based on age group. So in newborn babies up to 6 months of age, the common pathogens are group B strep and E. coli, both of which are contracted from the mother at the time of delivery, and also listeria. And so in this age group, for empiric treatment, before we know the pathogen causing meningitis, we use ampicillin and gentamicin. Remember what I said in the last slide, you don't want to use ceftriaxone in this group, so we use ampicillin, and we boost it with gentamicin to get better coverage of E. coli. For children from 6 months of age all the way up to adults of 60 years of age, this is the group where we use ceftriaxone and vancomycin. The major pathogens you're worried about in this group are strep pneumo and Neisseria meningitidis, and ceftriaxone and vancomycin usually cover those two bacteria very well. Beyond this, you can see meningitis in children 6 months to 6 years from H. flu if they haven't been vaccinated, or from certain viruses. Antibiotics obviously don't cover viruses, but I'm just showing you this here so you know some of the common causes. In children 6 years up to adults of 60 years of age, after the two big culprits, strep pneumo and Neisseria meningitidis, you can see infections from viruses like enterovirus and HSV. But once again, you get great coverage of all of these bacterial causes by ceftriaxone and vancomycin. In older patients 60 years and above, we give the same treatment as for younger adults, ceftriaxone plus vancomycin, but we add ampicillin. Why do we add ampicillin? That's because in this age group, listeria is a potential cause, and we want to cover listeria. Ampicillin has great coverage of listeria. That's why we use it in this age group here. It's also why we use it in newborns up to 6 months, because they can get listeria as well. And in the second video on meningitis, I will go into much more detail on all these individual pathogens and how they cause meningitis. And that concludes our first video on meningitis.